Good morning, Nigeria. Welcome to the 9 o'clock hour right here on Rapid Dawn. My name is Martha Alu.
And of course, my name is Victor. Okay, welcome to the big conversation.
Apologies for the delay, but we get right into the conversation. And right now, as we speak, the deadliest outbreak is nearly a decade, is tearing through the Democratic Republic of Congo and Uganda. Over 1,200 people infected and at least 349 dead. And the World Health Organization has sounded its highest possible alarm, a public health emergency of international concern. And what makes this outbreak uniquely terrifying is the strain driving it, the Bundibugyo virus, for which there is no approved vaccine, no licensed treatment, and a candidate vaccine that is still months away from even beginning clinical trials. Nigeria has officially classified its risk of importing this virus as high. And yet last week, the House of Representatives raised the motion warning that the very agency responsible for protecting us, the NCDC, is operating under a crippling funding crisis with rapid response teams untrained, laboratories under-resourced, and surge deployment systems weakened. So Nigeria allocates less than 6% of its national budget to the health, less than half of the 15% we committed to over 2 decades ago under the Abuja Declaration. Meanwhile, we have 71 cents of every naira spent on healthcare in this country. It comes directly from the pockets of ordinary Nigerians. We were able to contain the Ebola virus in 2014. The world celebrated us. But the question this morning is not what we did a decade ago. It is what are the systems that made that possible are still standing. And joining us now is the man at the center of Nigeria's response, the Director General of the Nigerian Center for Disease Control and Prevention, Dr. Olajide Idris. Good morning to you, Doctor.
Good morning. Thanks for having me.
Thanks for joining us on the show. All right, let's move right into it. Now, we see that the NCDC, your organization, has classified the risk of Ebola importation into Nigeria as high. And one of the major reasons for that would be our porous borders. And in one of the interviews you had on a live TV, you publicly said that Nigeria was 59% prepared to combat this, which is a number or a percentage that has echoed throughout the week. So our question this morning is, has this number moved from 59% upward, seeing the preparations that have been made?
Before I answer your question, let me just correct the wrong impression you created in your very introduction.
Okay.
I know that the members of the House of Representatives were worried about the situation in the country.
Yep.
Yeah, they were worried about the financial situation
Absolutely.
of the government. And let me say that NCDC is not the only organization that is affected.
Absolutely.
That is, most agencies are affected by this. That's one. Number two, when you say that the rapid response teams of NCDC are not untrained, that's totally false. Our teams are always ready. The system of rapid response is always the same for most of the diseases we will monitor and address. Okay. It's just that this particular one is a slightly different strain that requires some specific response to it. That's one. So now, to go back to your question, you said 59%. Yes, we did a dynamic risk assessment, a readiness assessment score, and it brought us to 59%. And we used the WHO tool for that, which is what is recommended. Now, 59% score, this assessment is done gradually, periodically. It's not that an assessment you can do every day or every week. Okay. And because there are certain expectations that are, certain infrastructures need to be put in place, certain things are measured. So, between the time I mentioned 59 and now, there's no way you can even do an underscore. But what I can assure you is that we've been at this thing for about 2-3 weeks now, trying to beef up our preparedness level. Yeah. And it takes quite a bit of time to do that. It takes quite a lot of resources to do that, because it cuts across different pillars of response. We scored 59%, and using the different yardstick measures they used. And there are certain aspects of that that were low. That's why it's 59%. And that one is also related to the kind of problem we have in now. Take, for instance, case management. case management for Ebola.
Yeah.
We only had Ebola 2014, and this second time we are having it. We have it here right now. Let me correct that. We don't have any confirmed case of Ebola in this country right now. But the essence is that we need to prepare as a country, just in case we do. And that's why, again, case management for that is quite specific. It's slightly different from what we did for COVID. And it's also related to the kind of mode of spread of Ebola itself. So it's got slightly lower case management. So that's preparedness assessment for us now to address those gaps, which involves training and retraining of health workers. The second bit again is on IPC, infection prevention and control. I'd say it's one of the easiest ways to contain disease of communicable diseases. But again, this is where again you have to build that culture, not only centrally, you build it sub-nationally, and right from even school. If you can inculcate the culture of infection prevention and control, we're in a better position to address some of these. So I can't tell you whether we move forward, but I can show you that if we do another score now, it's much better than 59%, because we've not been joking in the last 3-4 weeks.
All right. And of course, we'll see as well that recently the president approved 10 billion naira for health infrastructure and Ebola preparedness. Right. Now, given Nigeria's history for funds mismanagement when it comes to emergency issues like this, could you give us a specific breakdown on how these resources will be spent to ensure that all of these infrastructures are ready and better prepared for the outbreaks that we're having right now, first in Cholera, of course, even the intended Ebola?
When you say fund mismanagement, yes, I agree with you. I mean, it's a possibility. But in this kind of situation, if you have a potential outbreak that can kill people, and you manage funds, and there must be something wrong with you.
COVID-19 was a clear case as well. Recall that there were issues of funds management at the time.
I wasn't here when COVID-19 occurred. I was in Lagos.
Yes.
I didn't deal with money. I also do know that whatever it is, again, a lot of preparedness went into COVID-19. And we learned lessons from it, and that's what we learned. But let me say that the 10 billion naira the president graciously gave us, I mean, it just shows his commitment to this. When the matter was brought to his notice that this thing is raving in Congo and Uganda, and we did a dynamic risk assessment, and the risk of importation was declared high. So it was incumbent on us to start a preparation for, preparing for this. And the focus is that, first thing is that we do not want the virus into this country. So we do whatever it takes to prevent it from coming. And that's where activities will be at the ports of entry, involving immigration people and that kind of port health services, people manning our borders. Especially now that we have 5 international airports. But more importantly, again, our preparedness also goes beyond that. Just in case the virus comes in, we hope not, but if we don't, something have prepared our way. And that's why we have to address all the pillars of preparedness. About 9 pillars. A lot of them require money, many of them require money. It also involves, again, developing capacity of the state governments to be able to even respond should you discover the first case in those places. You might know where you come from. Most diseases occur from within the community. So it's incumbent on us now to develop that capacity and raise the awareness. So what to do in the past is that we are building capacity for case management, especially for health workers who see the case. We are building capacity for required infrastructure. Each state should have a treatment and isolation center earmarked. Yes, some of these were established during COVID a long time ago. I know typically once you don't use this, the chances are that it's going to deteriorate. The responsibility to ensure that those things are reactivated, properly resourced, and that kind of thing. That's one. Two, surveillance activity keeps money. That's the only way we can even trick. The easiest way, because like Radu said, this thing doesn't have vaccine, doesn't have therapeutics. So we rely solely on public health activity. The first one is detection.
Yeah.
We need to rapidly detect once it comes in. When you want to detect again, you either go through surveillance, and doing surveillance again, we look at different data of occurrences, cases, of things like this, and there are different routes or sources of this data generation. You can collect data from hospitals, especially when they see any infectious disease or whatever it is recorded. You can get from laboratories, you can get from pharmacies, you can get from even within the community. You have people, community informants. Once you hear of anything of fever, anything unusual, fever, it's an alert. And you get all this, you mine information from social media. People, it might be rumor, it might not be rumor, but you mine this information again, you look at events, everything. So many sources of information. You analyze this data. If you see a particular trend, a high incidence of things, it's a trigger. Now you send people to go and investigate in those areas.
Okay.
These people, again, all these activities cost money. It costs, you need human resources, you need materials, everything like that. Now, once you detect that there's something going on and you have samples, you have to send this to the laboratory. So it's incumbent on us to get our laboratories prepared. Now, for NCDC, we have a tiered laboratory system. We have a national reference lab, 2, one in Abuja, one in Lagos. We have zonal labs, but again, those zonal labs, again, were things we need to develop. Okay. So with this kind of money, the actually use part of it again to complete some of those zonal labs that have been left abandoned during COVID. So we started with 3 of them, so we need to complete those 3. The other 3, again, depending on how far this money goes, you have the 3. The zonal labs, again, are there. There are state laboratories that will support, because those laboratories were established for specific diseases. And the responsibility is that instead of spending a lot of laboratory written for one disease, can we improve the capacity for them to be able to detect more diseases using the same facility? The only problem is that you have different reagents, you may have different diseases. Yeah. Those are the things we are looking at now. But for Ebola, it's not all laboratories that can develop Ebola. They have to be specific. They are called BSS3 laboratories. We have 2 nationally, one in Abuja, one in Lagos. But we have the two brand, one brand new, one BSS3 lab in Lagos, one in Abuja. We are also using the laboratory at NIMA, National Institute of Medical Research. We used one in Luth. That was what we used to detect the first Ebola case in 2014. Okay. Now we have private laboratories that have the capacity to, one in Osogbo, one in Kano. And of course, the idea is for states where you have international airports, if you look at laboratories, they don't necessarily have to be public laboratories, private laboratories that we can partner with. Okay. We just boost, scale up their capacity to do that.
Right. Okay, so we have a number of questions we have lined up that we should ask for, of course, public enlightenment again. So let's just go over to them almost immediately. Okay. Now, you have made mention of some of these labs that have their capacity, even though previously in your interviews you said only few Nigerian labs can test for Ebola right now, and we're in a country of about 200 million people, yes, and these number of labs you've mentioned might not be enough to even serve the capacity of people we have in Nigeria. But that's not the point. I have a personal experience with an acquaintance who happened to go to the hospital, and they were suspects of either COVID at the time or Lassa fever, one of these outbreaks. And from the time when the hospital notified NCDC of this suspected case to when NCDC was present to test the case, we were already discharged from the hospital at that time. I do understand that you took this office in 2024, but because we're talking about preparedness, we need to make sure that we have all that it takes right now. So my question is, how long does it take to get confirmed diagnosis, and what happens in that window when the hospital has said this is a case that we have suspected, call out to NCDC? What time frame exists and what happens within this window?
Let's put in context. Okay. This hospital, how far away is it from?
It's in the FCT.
It's the FCT now.
Garki Hospital, precisely.
No. But I'm not giving excuses, but again, that the process is that when it comes to things like this, there are channels of communication. Because if you break that, it's a protocol. It could be evident. Because if you say you have a problem,
Yeah.
they first notify the public health people in FCT. They now determine what nature of disease is. Now, if they feel the thing they cannot handle that thing in the hospital, then they notify our lab. Now, it depends on what the diagnosis is. There's some of them you can get results within 24 hours or 48 hours. There's some you need to incubate that takes quite slightly a bit of a longer time. I'll give you an example. You can test for meningitis, but in our own job, it's not only testing for meningitis, you have to test for the strain, what's causing that meningitis, because that's what gives an idea of how you can manage it.
Okay.
Then trying to get that strain requires specific methodology, genomic sequencing. Not all labs can do that. And again, it depends on, how much of reagents they have already, how much cases, how many they have. So I'm not giving excuses, but again, the essence is that if you have reports of things being done properly, we take it up and address it.
She was asking about the time frame.
Yes, because they said they went through the right procedures. In fact, I was exposed, so I had to be put on.
Exposed?
Yeah, I was exposed because I had to be.
What are they thinking of?
I was put on ribavirin, which of course is
That's Lassa fever.
Exactly.
Okay.
So I was put on that because we sent messages to NCDC. Feedback didn't come on time. You know, I don't know if the hospital followed all of those procedures, but what happens during that window? Because it is risk. We're talking about prevention, right?
Yeah.
Or how to better equip ourselves to address this thing if it eventually gets into Nigeria.
If you were put on ribavirin for Lassa fever, I mean, ribavirin, you can treat that.
Okay.
You can treat that, so it's not this.
It was instincts that made us do that, not the diagnosis from the hospital, because they hadn't gotten a response from NCDC yet.
You see, that's the problem. But again, even instinct, if you follow the case definition for Lassa fever, if they feel it's Lassa fever, they put it straight on ribavirin.
If they feel.
If they are sure it's, I mean, they have a high level of association of Lassa fever,
okay,
they put you on ribavirin. So if it's Lassa fever, ribavirin, that's the essence they do. That's the treatment for that. Because the essence of Lassa fever to reduce death is that you present the hospital quickly. Once they put on Lassa fever, ribavirin, at least, yeah, more or less safe. But again, I'm not giving excuses for. The idea is that everybody must be up and doing.
Absolutely.
So I'll tell you, it's not impossible that they didn't take the specimen correctly. I don't know, but I'm just.
Right.
But we look into it. But again, we don't want that kind of thing to happen.
Definitely. And of course, again, you were a commissioner of health in Lagos State for 2014.
My twin brother.
For 2014. And of course, within that time, the Ebola outbreak came on board, and you were able to contain it. Your ministry was able to contain it, in Lagos State. And once a kudos to you on that particular good job. And one of the things that we saw that you did was the creation of the isolation center, right? In many parts of the country, Nigeria, there are talks as well that now there are certain isolation centers, but some of these do not have proper ventilators that function properly and don't even lack running water. My question again is, why has it taken the country over a decade to be able to begin to look into these isolation centers now? Why did it have to take another outbreak before this?
Let me. No, the story created, you don't know how the isolation centers were created in Lagos.
No,
it took quite a while because we didn't even know what Ebola was there. Let me promise you. And again, a lot of the centers that they started with were not properly designed.
Okay.
And for Ebola requires specific design, because now you have to decide, we have to look at the airflow, flow of this wastage and that kind of. That was the first time, we ever looked at that. Now, the isolation centers created in Lagos then, courtesy of the private sector. So when they were temporary.
Okay.
Because it took a while again. I mean, you can't find it again because one, like Riley said, after the thing died, management was, usage of those materials again. And it's not everybody that was trained in the using of all these materials. So they were temporary. So the incumbent on us are to create standard treatment centers, properly designed, that it can use for many diseases. Now, for Ebola, I remember a case in Lagos, the first treatment center I wanted to do, they started building even before I came in. The MSc people said, that's wrong. Because you build the thing, you put AC, but again, you have to decide on the mode of spread of this particular organism.
Okay.
So it's not everywhere you need AC. Maybe you're going to use AC, there are different ways of putting it. So it's a design issue. Now, when you say nobody knows when Ebola will strike, now, we are contending about 8 outbreaks in these different outbreaks apart from Ebola.
Yeah.
So we have standard structures for those things, similar things. But again, the isolation center used for Ebola may not necessarily be good for, let's say people are not, may not necessarily be used for Ebola.
Cholera as well.
So specific centers for?
No, yes, specific design requirements, especially because you need to be sure that the disease is not spread.
Okay.
Anything that you're having with maybe that spread is through, what do you call it again?
Human contact?
Yeah, but
Airborne?
With airborne or airborne, that is different from where you contact by contact. So designs are different.
Okay.
The other issue is that if you look at economics, it's not only in this country. Even in developed countries, nobody in developed countries keeps an isolation center, for Ebola, because they don't know when you have an Ebola. What they do is because they have that engineering prowess, engineering capability. It is engineered in such a way that they can easily amend when it happens. We haven't in that situation here. And again, if you have to do that, it has to have the continuous maintenance for years, which costs money.
Okay.
In a situation where healthcare funding is a bit, and it's a matter of economics, for instance, now. But again, if you develop that culture, that capabilities throughout the year, these are things, that's the focus here.
Okay,
because before Ebola, before COVID, we're not prepared for things like this. It's the COVID and Ebola that actually opened our eyes
to see that.
And that's when now we say, look, you can go to the hospital, someone has malaria, he dies of malaria, COVID, yeah. But if you calculate the number of people that will die in 1 year, compared to the number of people that one epidemic will kill, they're not comparable.
Okay.
So you understand me? They're not comparable. But that's why, again, it's incumbent on any government that you set up systems within your organization or institution to be able to track these things and start planning over the years. And there are basic public health infrastructure you need to put in place.
Okay.
Not only hospitals. And that's why in this environment, everybody concerns hospital, hospital, hospital. You understand me? But hospital, if you don't take care of public health infrastructure, public health, and it cuts across. And those are the things you need for epidemics like this. It also involves training and changing culture of people, especially with respect to communication and all. And take, for instance, Lassa fever. What causes Lassa fever? That rat. In those Lassa fever areas, that rat is a delicacy. You find it very difficult for people to stop eating rats. So the rat is that you say, if you want to eat rats, do it the way that it is safe for you and that kind of thing. Hand wash it, all those sorts, cook the rats properly. But if you say stop eating rats, it's a problem. But again, rats, deratification or rodent control, everything, is outside the purview of NCDC.
Okay.
That's why it's a One Health issue.
You say outside the purview of NCDC?
Outside the, just so, because our time is fast spent, honestly, I would want to touch a bit on cholera, because there's also an outbreak here. Yes, there's also an outbreak here in Nigeria. Yes, but let me just ask about the meeting in Victoria Island, the task force meeting that was held. It had the Minister of Interior, Aviation, the Chief of Staff is heading the task force committee and all of that. And seeing the sensitivity of this case and how quick it can spread and become fatal, right? We have established that funding is a primary issue here. And if we have the right funding, we can combat it as fast as possible. But you see, we didn't have the presence of the finance minister there, which I did believe would make the process of disbursement and allocation of these funds easy enough, seeing the sensitivity of this case. So who controls the budget, and how quickly can the money actually move to begin this process?
The finance minister doesn't necessarily have to be at that meeting.
Okay.
All the finance minister used to do is take instruction from the president, and there's a process for fundraising in government. It has.
So that's the issue we're addressing, the process, how long it takes because of how sensitive the case is.
I can't give you an answer because I don't deal with money.
Okay.
But again, I also do know that when it's an emergency, certain bureaucratic systems are overridden to ensure that. From what I gathered, after the approval, I know I'm going to send some memo to the finance minister to ensure that that is released quickly.
All right.
Because the finance minister doesn't necessarily have to be at that meeting.
Okay.
All right. So
the people at that meeting are people who have connection or control over the activities within the port, the points of entry, which is my own first strategic approach. And that's why you had the Minister of Interior, FAN, NCAA, Immigration, Customs, NCDC, and Lagos State, because Lagos State has to work with Port Security, just like another airport.
Let's quickly jump into cholera, because again, during your tenure as Lagos Commissioner for Health, you battled cholera, you know, in the part of Motion, Makoko area. But let's start with the basic. What causes, Motion axis rather, what causes cholera? Let's start from there.
Cholera is an organism that you find in, that affects what is called the fecal oral pathway. Taking through your mouth through different means, either from infected food or contaminated water you drink, and it causes some reaction in your body that produces diarrhea. For diarrhea, you lose a lot of water, fluid. So the first one is if you don't quick rehydration. That's why I call oral rehydration therapy. You tend it to also put on a drip to rehydrate. Once you can properly rehydrate, you're doing okay. But if not, that's what kills dehydration. Now, when you say fecal oral matter, you ingest, you drink, and you pass out the waste, fecal matter. The cholera organism is still there. Now, why I look at cholera as a development issue. You understand me? People with cholera, they see the doctor treats them. But what actually happens, which brings again to the issue of pain. There are certain aspects of our community, if not taking care of, they have positive effect on health. Poor water supply. It's a problem. If there's no water source or clean water source, it's a major cause for cholera. Open defecation, which is rampant in this country. I think only a few states that are open defecation free, which are bad personal habits, bad environmental habits. They have an environmental issue, poor drainage, poor sewage, poor disease. All sorts are outside the purview of NCDC or health sector.
It's outside your purview?
I don't deal with drainage system. I don't deal with sewage system.
But you deal with the outbreak. The outbreak.
I deal with the outbreak. What I'm saying that if we deal with all these things, you prevent outbreaks. Or it makes outbreaks prevention easier.
So, wait. The outbreak,
again,
is it predictable?
If you have flood, what?
Is it predictable? Talking about cholera, is it a predictable disease outbreak?
But cholera occurs all year round.
Yes. And if
wait. Cholera is cholera all year round. It may not be at the level where you call this an outbreak. Now, in some parts of the country, you have increased number. Those areas, again, if you look at the structure of those areas, culture of those areas, you say they have things like open defecation, poor drainage system, poor sewage systems. And when rain falls, that's why it's more common in rain season, you have flood. Now, where you don't defecate properly, where your sewage system is very poor, where your drainage system is very poor, when rain falls, this flood mixes everything together, contaminates your water source. And that's where that cycle started. You understand?
Yes, we do.
And that's why, again, drainage system, sewage system, personal hygiene, environmental hygiene are key issues here.
So it's a collaboration between you and those responsible. It's a collaboration
with all the agencies of government involved in all this yard. And put it again, that's why the issue of physical planning, town planning is key. Because when you're doing physical planning, town planning, all these things are taken into consideration. Drainage system, water system, power, right? Waste disposal. But in the environment, how many states does that?
But is the NCDC structurally designed to handle multiple outbreaks at the same time? Because we're dealing with Ebola now. It's not yet in Nigeria, but Nigeria
is already handling multiple outbreaks. I can tell you we're currently handling 8 outbreaks, minimum 8 outbreaks now.
Nigeria. Okay. How's that going?
We're still surviving.
Yes, surviving. Are you on top of it?
Yeah.
We're on top of it, but if not, many people would have been dying. But again, there is a what is a soft spot?
Okay.
An area now where we need to address.
Okay.
NCDs can be everywhere. So it's incumbent on us now to develop those capacities at the state level. Because this has happened at the state level. Take for instance what happened in the mention cholera. What happened in the where's that? Up north, Bono.
Okay.
What happened?
Are you training at the sub-national levels? Because again, if you have identified that this should be done also at the sub-national levels, what are you doing to ensure that these people within those levels handle it?
Before, each state is its own government. And now we are working now hand in hand. This is a recent focus that we can't continue doing things the way we've been doing before. You need to train, you need to work together on this. Bring the attention of the state government, local government on things like this. You draw their attention again. You develop capacity. When you have an outbreak, what does NCDC do? We send people, rapid response, if it's something they can't cope with, to go and help them. We send them materials. We train them, different materials. Again, we expect them now to actually replicate that once they build that capacity. What happened in Borno State? You had a dam that broke. You had a flood. Like I told you, drainage system, water system, everything mixed up together. But our people were there and they were telling them what to do. But again, the diagnosis was made in teaching hospitals. That's not under our direct control. They were misdiagnosed as acute watery diarrhea until they were told what to do.
Okay. Our time is fast spent and we'll definitely have to go now. But I mean, there's so many areas that we'd love to explore. Maybe we'll have a rematch with Dr. Idris if he approves. We have to pay. we're just another chain of NCDC. Just yes, but just another chain.
Basically.
Yes, but the communications chain of NCDC, right?
Oh, okay. You disseminate
the information.
So we're already working together. Thank you so much, Dr. Idris, for joining us on the conversation this morning.
Thank you very much.
All right. If you are just joining us, we have sat with Dr. Olajide Idris, the DG of NCDC, and we have been having conversations regarding Ebola preparedness and the cholera outbreak we have in Nigeria. And just to wrap it up, we'll remind you that we are active across social media platforms, on Facebook, on Instagram, on X, and on TikTok. It is at Rapid TV. On YouTube, it is at Official Rapid TV. So yes, if you want to know what the NCDC is doing regarding curtailing this outbreak if it ever gets into Nigeria, please do well to share the links to your friends just so they know. Our website, www.rbnradiotv.com, allows you to connect with us from anywhere in the world. Thank you again for joining us on the show. My name is Martha Alu.
My name is Victor. Okay,
we'll see you tomorrow.